I am Dr. Kumareson, and my topic today will be diabetes in adolescents. So we're going to focus on diabetes in adolescents, especially namely in Malaysia. And in my first slide that we can see here, how alarming diabetes is in Malaysia. As we can see throughout 40 to 50 years, there's just basically an exponential growth. And unfortunately, Malaysians are the fattest in Asia by far in comparison to our neighboring countries. So let's look at diabetes. Basically, we are going to focus here on type 1 and type 2, namely mostly type 2 diabetes. So my presentation would be a real case scenario that we have seen in our wards. As a 23-year-old engineering student who presented with vomiting and abdominal pain for the past 2 weeks with giddiness. Further on in history, he has got nocturia, polydipsia for the past 2 months now. He's no fever or any chronic cough, but he's got a very strong family history of diabetes and hypertension. Unfortunately, he's a smoker, but he's a teetotaler. He works as a part-time Grab delivery service boy, and on examination, he was obese with a BMI of 31. He had nicotinic stains over his fingers, but he had also presence of acanthosis nigricans. There were multiple dermopathic spots on his legs. His vitals were fairly stable, which the BP was borderline high, and also his sugars were around 22. This was a random sugar. Now his fasting sugar was 14.6 and his HbA1c was 7.2%. He had some protein in his urine, and otherwise our diagnosis at that point was type 2 diabetes in adolescents. Now, looking back at diabetes as a whole, now diabetes is a very huge spectrum of a disease. It's been very well investigated and worked on throughout these years, and treatment options are also there. So let's classify this diabetes mellitus. So we've got type 1 diabetes, which is mostly autoimmune mediated, and type 2 diabetes, which is what we famously see in our country. And type 3 diabetes, which are all the subsets and gene mutations that we see, MODY, which is maturity onset of diabetes in the youth, which we have from number 1 till number 6 with X gene mutations, which are not very important for us at this point now. And there are some diabetes associated with genetic syndromes, with drug therapy like antipsychotic agents, and as well another type of diabetes that we commonly see in our populations are also gestational diabetes mellitus in pregnant mothers. So let's look at just the simple diabetes differences between type 1 and type 2. Now, why this happens? In type 1, your body doesn't produce any more insulin at all. In type 2 diabetes, to a certain degree, it produces some form of insulin, but it's not efficient enough in producing enough insulin for the carbohydrates that you consume. And then age presentations, type 1 present very much earlier in life and present mostly in childhood. By the time they reach teenage or adolescence, they present to us with various symptoms. Now, type 2 diabetes generally present over advanced ages, 20, 30s, or even 40s. Now, unfortunately, we are seeing younger and younger age group children and adolescents presenting with type 2 diabetes. Now, the risk factors are fairly the same, of which type 1 diabetes is mostly family history. In type 2 diabetes as well, is a strong family history, which is a high preponderance of developing the disease, and of course, overweight and high blood pressure as well. The symptoms are fairly the same of both type 1 and type 2. And how do we prevent type 1 and type 2? Type 1, there were no prevention methods that we could actually denote to say, but type 2 was basically healthy lifestyle. Now, looking at the type 1 and type 2 differences. Now, type 1 generally present to us with ketoacidosis, that is just basically very high sugars in their body with acid accumulation in their bloods. So they have elevated blood glucose levels, and upon examination or presentation or investigations further on, they have positive antibodies. In type 2, basically, they come in with very high sugars. They just don't generally present much with ketoacidosis, but yes, elevated blood glucose. They don't have positive antibodies, but they have elevated blood glucose as to the numbers that we see over the right-hand side. With a random blood glucose of more than 11, you're fasting more than 7, and a 2-hour post-OGTT of more than 11 as well. Let's look at the risk factors of type 2 diabetes. Now, type 2 diabetes, I mentioned, is seen in family, so it can be seen in first or second degree relative. Obesity, which is almost 95% of our type 2 diabetes that we see nowadays, impact glucose tolerance, and somewhat some hormonal imbalance conditions like polycystic ovarian syndrome, exposure of diabetes in utero, as we mentioned, in gestational diabetes mellitus. Now, acanthosis, the presence of acanthosis nigricans or even hypertension and dyslipidemia are also risk factors for type 2 diabetes. Non-alcoholic fatty liver disease and the usage of antipsychotic medications are also minor risk factors for type 2 diabetes. Now, type 2 diabetes is growing in younger children, putting them at great risk for diabetes, and not only diabetes but heart disease as well. And this is contributed basically by sedentary lifestyle, inadequate exercise, supersized eating habits. We go to McDonald's and we have super extra large, massive, large, whatever numbers you can get them nowadays, and also puberty actually exacerbates the incidence of diabetes because it reduces the peripheral insulin as some form of hormones actually are diabetogenic. But looking back at first indicator and second indicators, these are the bigger risk factors in developing diabetes: sedentary lifestyle and inadequate exercise. Type 2 diabetes has been reported actually in children as young as 4 years old. How do we screen them? So basically, recommended screening test is basically an A1C plus a fasting or a random plasma glucose. If there are discrepancies in your A1C, your fasting, or your random plasma glucose, then they warrant to go for an oral glucose tolerance test. This is just basically done in your primary healthcare level, your secondary levels, and even your tertiary hospitals as well. It's easily done anywhere, in even at your own home as well. So looking at your values for diagnosis of venous plasma glucose in a patient with type 2 diabetes, a fasting of more than 7 and a random of more than 11. I remember it as 711. And looking at your A1C, I only remember diabetes just being more than 6.3%. And looking at your OGTT levels, I just remember the ones which are normal, 6.1 to 7.8. So I just remember 6, 7, 8. These are numbers that we probably may forget as time goes by. So these are earlier and easier ways to remember them. So looking at the symptoms we've already mentioned before, we have polyuria, polydipsia, nocturia, unintended weight loss, polyphagia, basically eating more than usual, fatigability, frequent infections, and acanthosis nigricans. So acanthosis nigricans is something that we see in a clinical feature of type 2 diabetes, almost 73% of our proportion of type 2 diabetes alone. 95% of obesity is seen in type 2 diabetes, but you see diabetic ketoacidosis is only 10% in type 2 diabetes. Yeah. So this is what we call as acanthosis nigricans, darkish appearance over the darkish thickened skin appearance over the flexural regions of your skin, basically at the nape of your neck, your axilla, or your internal groin area as well. These are indicators of type 2 diabetes. So diabetes, when we come into their management, we have non-pharmacological and pharmacological. And I believe non-pharmacological management is somewhat more difficult than pharmacological management, as it comprises of basically diet changes, food exchanges, exercises, medication, the complications of the medication, going home and doing a self-monitoring blood glucose level, monitoring their weight, blood pressure, food care, stopping smoking, when you start them on medications, hypoglycemia and awareness, and a lot of psychosocial management as well. You can always have a support system, diabetic educators, support system, like a diabetic group for your patients, and also telephone contact. Now we have WhatsApp, we have Zoom, we have so many other management methods of getting to know how our patients are at home with diabetes mellitus. Looking back at pharmacological aspects of management in diabetes, now there are an array of medications that are available. The ones I've highlighted in a different color are the ones which we are commonly using them, and we famously see them in our prescriptions these days, and especially available in our Ministry of Health. So these are medications, metformin slow release and extended release, and of its doses as well. You can look on and find this in the Malaysian CPG guideline. Sulfonylureas being glibenclamide, glipizide, and glipizide MR, and those meglitinides are not commonly used in MOH as well. Alpha glucosidase inhibitors, fairly an old drug, of which it's a carbose, and it's almost extinct now, but we still see them being used these days. Thiazolidinediones are not very commonly used. DPP-4 is fairly new medications that are being used, so we see them like sitagliptin, vildagliptin, saxagliptin, and linagliptin. These are available ones. SGLT2 inhibitors are even more new medications, and examples of dapagliflozin, canagliflozin, and empagliflozin, which are readily available. There are some injectable agents. These are not to be confused with insulin. Yeah, these injectable agents are not to be confused with insulin. So they are glucagon-like peptide GLP-1 receptor agonist. They are not like insulin. Insulin is basically recombinant DNA of your human insulin. You deliver that via an injectable method as well to your patient. So these are not the same. So these medications are exenatide and liraglutide, which are expensive medications. They are used in KKM formulary, but are not famously used because of cost barrier. Otherwise, they are excellent drugs, and we're not going to delve into exenatide and liraglutide as much, as we don't really see them as much. But we're going to do much more in insulin therapy and the type of insulin therapy. They are short-term uses for basically patients with high sugar during acute illness, after surgery, pregnancy, breastfeeding, and maybe some conditions like DKA or even HHS as well. It can be as an initial therapy to a newly diagnosed type 2 diabetes if his HbA1c is screamingly high of more than 10%, or his fasting glucose are more than 13, and later on we can down titrate them to oral hypoglycemic agents when the sugars are much better controlled. So these are various types of insulin that we find in our formulary as well. We have short-acting medications like our famous Actrapid, Humulin R, Insuman R, and Insugen R. These are just different derivatives of preparations, but their functions are basically almost the same. Yeah, so we have analogs form of short acting, which are aspart, lispro, and glulicin. In basal insulins, we have intermediate acting like your famous insulatard and your humulin N, insumin N, and insugen N. And of course, your long acting analogs like glargine or detamir or degludec. So premixed insulins are your Mixtard 30, your Humulin 3070, your Novomix, and also various kinds of preparations of Humalog as well. Now, self-blood monitoring of your glucose, it should be recommended in patients on insulin and desirable for those on oral anti-hypoglycemic agents. The frequency of this testing depends on glucose status and glucose goal, but mostly our patients are financially burdened by buying strips or buying the meter for that. So these are few suggestions that we can give them, recommend them for self-monitoring of blood glucose. So if you're on diet therapy alone, perhaps you can check your breakfast pre and post, lunch post and dinner post and pre-bed. But famously, let's look at insulin therapy. They require them to check at every meal pre and post to see how much of insulin is basically being used and being consumed by your body, and is it adequate or is it subtherapeutic. Now, these are conditions where it is a little tough for our patients to inject themselves 6 or 7 times in a day, and to get that, to get that reading, I think most of us have never achieved any form of percentage with our patients. So I think it's advisable if they even do pre-breakfast, pre-lunch, and pre-dinner and pre-bed for once in a week, or once in 2 weeks will be actually great enough to actually see. By the time we see them in our clinics, maybe in 3 or 4 months time, we will probably have more than 12 or 13 readings of this fashion. So these are suggested treatment approaches for patients with insulin, a normal weight, overweight, obese, and increased risk of hypoglycemic patients and CKD patients. So this chart is basically seen in and found in our CPG guidelines as well. Just basically, most of them are started on metformin as first line, except the CKD group where you half the doses based on their EGFR. Now, if you look at the second line, a lot of them are proposing DPP4s like your vildagliptin or your saxagliptin or your sitagliptin, and also SGLT2 inhibitors. So SGLT2 inhibitors are good for obese patients or even heart failure patients as well. Third line being you can promote your sulfonylureas, which is your famous glycoside, or you can continue with your dapagliflozin, which is your SGLT2, and also you can also promote a DPP4 as well. You can overlap these as your third line later on. So, and when you go on to your fourth line, basically you're caught on with probably starting them with insulin, basically a prandial insulin or a basal insulin. But most of the time, I think we see our patients in almost a stage 3 or stage 4 and above. So basically coming to just a touch of what's type 1 diabetes, it's insulin dependent. I told you in the earlier slides, your body do not produce any form of insulin. Your beta cells in your pancreas is basically denatured and destroyed during in utero. So you are basically insulin dependent diabetes mellitus. The average of onset, as I've mentioned, it's basically in childhood and early adulthood, usually before 30 years old. So I've just mentioned just now is pancreatic islet cells destruction predominantly by an autoimmune response. That's why you famously see these type 1 diabetes patients having antibodies towards which you can find in their blood levels. So which is not related to diet, activity, or weight especially. It's not preventable. It evolves over weeks to months. A good control of diabetes will decrease the term of long-term complication and risk. And these are the few antibodies that we find in type 1 diabetes. Islet autoimmunity can be detected in multiple islet autoantibodies and their characteristics. So we have IAA, IA2, insulin antibody levels, and also GAD levels, glutamic acid decarboxylase levels. So these are a few of the antibodies. There are actually more antibodies that we have come across, but of which these are the ones which are more famously investigated on. So this actually basically concludes my entire slide presentation, as I have basically enumerated the risk factors, clinical presentation in the clinical scenario, and how we form of investigate these patients of probable diabetes mellitus, just looking at the presentation and the morphology and the demographics of the patient, being obese, overweight, with a family history, with presence of acanthosis, and somewhat high levels of sugar levels. So maybe these form of individuals are what you are basically seeing as type 2 diabetes. And it's a common problem that is going on in our country. Diet, exercise, a sedentary lifestyle is a number one causative mechanism and risk factor for our type 2 diabetes as well. So we have also touched on with various kinds of treatment modalities of type 2 diabetes, non-pharmacological and pharmacological, the availabilities of oral anti hypoglycemic agents, and also some form of new injectable agents. And we've also touched on with insulin therapy, of which a lot of us are quite used to. So, and further on, we've also highlighted on type 1 diabetes and what they normally presenting with ketoacidosis, screamingly high sugars with a lot of acid accumulation in their blood glucose in their blood levels, that would present to you at presentation basically as diabetic ketoacidosis. And their form of therapy is basically carbohydrate management, and also number one, insulin. And there is no other form of treatment for this type 1 diabetes. So I hope you understood and enjoy. Please do go back to the CPG for diabetes mellitus and you'll find more information there. Thank you.